Hi everyone, my name is Jeremy Smith and I'm a PA at Stebbin Hawkins Clinic. I work with Dr. Genuario, and today we're going to talk about ACL injuries and how we fix them surgically.
All right, we're going to talk about ACL surgery. And the first thing to do is review the anatomy of the knee. If we look at the picture on the left-hand side, you can see a complete tear of the ACL ligament right through the middle of the knee. Of course, the ACL helps with stability. If you look at the picture on the right-hand side, you can see a side-to-side view of the knee as an MRI, and you can see the yellow arrow is pointing to a mid-substance tear in the ACL. Remember, these ACL tears typically happen from a non-contact injury. And next, we'll talk about some treatment. Let's review the treatment options for ACL injuries. So one option would be to do physical therapy to try and avoid surgery. The physical therapy would be used to try and decrease the swelling and regain the range of motion in your knee, and also to strengthen up the muscles surrounding the knee to provide stability for the non-functioning ACL. This is certainly an option if you don't have any associated meniscus tear and you plan on doing primarily linear sports such as jogging, walking, or swimming. If you're planning on doing cutting sports like soccer, tennis, or football, then it's likely you will need ACL surgery. Now, we also do physical therapy if you're going to have ACL surgery, as it's preoperative physical therapy to regain your motion and decrease your swelling. It's important to have good motion prior to surgery to try and prevent stiffness after surgery. If you operate on a super stiff knee, then typically after surgery, you're also going to have a fairly stiff knee. Another option for treatment is ACL functional brace. So some patients that are trying to avoid surgery on their ACL, they'll use a special brace to help with stability. Another option short-term would be using some anti-inflammatories to decrease the swelling in the knee and help regain your motion. And another conservative option would be changing your activities, as we mentioned, avoiding cutting sports like soccer and tennis, and sticking to linear sports such as running and walking. So ultimately, most patients are going to end up deciding they need ACL surgery to make their knee feel stable and allow them to get back to activities they enjoy. So let's talk about what's involved with ACL surgery. So I want to take you through the day of surgery. First, we're going to have you arrive about 2 hours before surgery to get prepped for surgery. You'll meet with the nursing team. They'll get you all set up for surgery and put an IV in. You'll meet with the anesthesiologist. They'll discuss the anesthesia options, such as doing a general anesthetic where they put you to sleep, or possibly a general anesthetic with also a nerve block. The nerve block can be helpful for pain control for 24 hours after surgery, but that's certainly your option, as there's plenty of patients that don't do a nerve block. Following meeting with the anesthesiologist, Dr. Genuario will be by. He'll review any last-minute questions with you, and then he'll initial your operative side before you head back to the surgery room. Now, ultimately, the surgery is an outpatient surgery that takes about 1.5 to 2 hours to fix your ACL and also do any meniscus work that is necessary. Following the surgery, you'll go to the post-anesthesia care unit or PACU, where you'll recover from surgery, typically for 1 to 2 hours. The nursing team will make sure your vitals are good, you're able to eat and drink something, and your pain's well controlled before going home. Remember, typically this is an outpatient surgery, but if for any reason your pain's not well controlled or you're having trouble eating or drinking something, then there is an option to stay 23-hour observation where you stay overnight for surgery and go home the next day. But remember, most patients just go home a couple hours after surgery. Let's review some of the potential graft choices we can use to replace your ACL. So first option could be using your own hamstring. One of the advantages of using your own hamstring is it typically has better strength than a cadaver graft, but one of the disadvantages is it may leave you with some mild hamstring weakness in the long run. Another advantage of the hamstring graft is typically patients don't have problems with anterior knee pain or pain in front of their knee following their surgery and when they're going through rehab. Another option for using your own tissue would be your own patellar tendon or your own quad tendon. When we do this, we take the middle third portion of your tendon and use that as your new ACL. This typically has better strength than a cadaver graft, but the disadvantage is it may leave you with some pain over the front of the knee in the long run, and certainly sometimes some pain in the front of the knee as you're getting through the initial portion of rehab. And a final option could be using a cadaver graft such as a patellar tendon or hamstring tendon. Typically, if we do that, initially you have less post-operative pain, but one of the disadvantages is it may lead to more failure of your ACL if you're a younger patient. So typically, if you're 35 or under, we recommend using some of your own tissue, such as the patellar tendon, quad tendon, or hamstring tendon. But if you're over 35, it may be reasonable to use a cadaver graft. Let's review the different types of incisions we use with ACL surgery. So everybody's going to get a portal incision on each side of their knee, which you can see on the picture on the left-hand side. Now ultimately, the picture on the left shows what type of incision we do if you use your own hamstring, as we use this incision to harvest your hamstrings and also to put in the new ACL. It gives us access to drill bone tunnels through the tibia or your lower leg bone and also through the femur. We can use that same incision then to fixate your ACL in the appropriate position. Now the picture on the right-hand side shows the options of using your own patellar tendon or your own quad tendon. You can see where we would make the incision if we used your own quad tendon towards the top of that picture, and you can see where we would make the incision if we were going to use your own patellar tendon towards the bottom of the picture. You can also see a dot on each side of the knee for what we would use as your portal incisions. Now ultimately, if we did a cadaver graft ACL, your incisions would look more like the picture on the left-hand side, as those two little portal incisions and also a place to put in your cadaver graft ACL. It's also worth noting that patients that injure their ACL will frequently also have associated meniscus tear. So if we're fixing your ACL, we'll fix your meniscus at the same time. They've shown in studies that if we have to repair your meniscus, when you fix the ACL at the same time, that leads to the highest healing rate. You can see in this arthroscopic picture how we have 2 stitches in the meniscus after it's been repaired. Now in some cases the meniscus won't be repairable because it's in an area where the meniscus will not heal. And ultimately, if you had that, we would trim just a little portion of the meniscus out at the same time of fixing your ACL. They've looked at it some in MRI studies and saw that maybe even up to 20% of the time you can have a normal looking meniscus with an ACL tear, but still have some small meniscus tear. So we always are looking for that during surgery and take pictures of your meniscus. And if we see any meniscus tear that wasn't visible on the MRI, then we would want to fix that meniscus tear at the same time as doing the ACL reconstruction.